Thanks very much, Cameron. Nothing like setting me up for a fall. Yeah, last talk before lunch and following the slickest PowerPoint presentation I've seen so far, so thanks very much, everybody. My name's Andrew Wyborn. I'm the CEO of a company called Greenmash, and I'm going to tell you about how we've actually employed or deployed an mHealth application in Cameroon. My agenda, which I haven't actually written up, but my agenda is I'm going to tell you who we are, what we do. I'm going to give you a little bit of background about the software application that we use and how we deploy it, where we deploy it, and then get on to the interesting stuff, which is what we've done with an NTD program in Cameroon. So the players in this, there's always multiple players. We've got the Ministry of Health in Cameroon, Site Savers, and Greenmash, and we have a look a bit more in the background. Site Savers are a UK-based charity. They're an NGO, effectively, working in multiple countries, obviously focused on blindness issues, of which neglected tropical disease is a big contributor. We as a company, Greenmash, were already working in Cameroon with the National Malaria Control Programme, where we've deployed our mobile health application to enable the National Malaria Control Programme to collect commodity data on a weekly basis using SMS, so real-time data collection using SMS, and on a weekly basis, monthly, they send in surveillance information using SMS, and it enables the National Malaria Control Programme to actually see what's going on and make informed decisions about how they can improve the malaria programme. We're doing that with an application called Mango, which I'll tell you a bit more about in a moment, but it's a software application platform that we can configure to support multiple applications, irrespective of the disease type. And we're a UK-based, Greenmash is a UK-based software and services organisation, and we're operational in, at the moment, 9 different sub-Saharan African countries, including Cameroon and the others you can see up there. Okay, so Mango, as I say, it's a mobile application platform. So what does that mean? Well, it means it's a software application, sits in the cloud, it's highly configurable, so we work with clients to say, okay, what data is it you're trying to capture? What do you want to do with it? Who needs to see it? Are there processes that you need to automate? Are there alerts that you need to raise? Basically find out what the scope of the requirements are. We then deploy it test environments, people can see what's going on, and we also look at the local environment and say what is available to enable us to capture that data at source, at the community level or the health facility level. And typically, they'll be, in Cameroon, for example, the only thing that was common across all of the regions that we're working in is SMS technology, so text messaging. So we thought, okay, fine, we'll use text messaging because we're independent of the means of capture, so we can use SMS messaging, smart devices, web forms, paper, doesn't really matter. And so we get involved in typically last mile solutions. So if there's a problem where you need to get data from a hard to reach place into a regional, district, national level, or even global level to make informed decisions, that's where we fit in. This is how the Mango platform fits together. I'm not a technology person myself, so this suits me very nicely. So the blue bits are the inputs, so we get data from whatever's available, as I say, mobile phones. John held up a couple of very smart-looking smartphones, but typically the people who are interacting in Cameroon aren't using those. They're using sellotape together bits and pieces of old phone that just about manage a SIM card. As long as they can send and receive a text message, they're, game on. Smartphones, we have smart applications. We've been working, as John says, with Amiga Diagnostics to enable them to capture and send up their diagnostic results. We can import data from third parties, we can scan paper, we can collect data through web forms. But the key thing is we get the right data in real time into Mango. The configuration for the program within Mango will enable the data to be turned into information, and then we can push that information out in whatever form is appropriate. So we can send out email reports to district managers or program managers. We can push up web reporting for people who have access to the internet. We can even send out simple SMS reports back down to the districts and to the health facilities to let them know what's going on, which is a key component of two-way communication. We can also integrate with third-party systems. So for those of you who are familiar with DHIS2, District Health Information System 2, which I know is used in a lot of sub-Saharan African countries, we have a integration level with DHIS2, so we can give basically we can give national health systems complete visibility right from the primary level or community level up to national level. Examples of some of the projects we work in, as you see, multiple countries, multiple programs. To us, the program type, the disease type is irrelevant. If you need to get data and need to turn the data into information and make decisions, come and talk to us. So we're working in all of these countries. We do a lot of work with malaria and HIV, obviously the big disease areas. We're working with NTDs in Nigeria and Cameroon. We do a lot of supply chain work because at the end of the day, a lot of the stuff we do is giving visibility to what's going on in the health facility. And one of the key things is you need to make sure you've got the right commodities available. So we do a lot of commodity tracking, inventory management, ordering, generate reports for stock reallocation. But we also do a lot of other stuff as well. We support, we enable protocols to be followed on electronic devices out in the field. So, if you need your partially trained clinical workers to actually adhere to the WHO protocols for malaria, IMCI, for instance, we've got applications that enable them to do that. So you can track what they're doing in the field, and everything we do is linked to the cloud-based Mango application. So the program managers, doesn't matter how far away they are, if they're the other side of the world, they can see what's going on right down at the primary care level. Okay, so the thing that links all of those projects together, the common thread, is that collecting data from tough environments, translating that data into something that's meaningful, that can be used, and doing that in real time. I mean, all of the data that we collect, as soon as it hits Mango, within 15 minutes it's available through the web interface. Making that information visible to multiple partners or participants, so it doesn't matter if it's donors, implementing partners, people on the ground, anyone with authorization to use that data or information can access it through a simple web browser. And ultimately, what we're enabling people to do is make informed decisions to improve performance management. So it's not guesswork, it's not we're doing it like this because we did it like this last week or last year. It's informed decisions based on what's really happening. Okay, so coming back to Cameroon and the NTD program, as I say, we're working with Site Savers. And the reason Site Savers came to us and started working with us is because they'd identified some serious issues with their MDA, the Mass Drug Administration in Cameroon. So there were delays in getting the census and treatment data from the field, sometimes weeks or months before they got accurate data coming across. Incomplete treatment data even during the reporting period. It was very difficult for them to monitor what was going on once the Mass Drug Administration had started, so they're effectively flying blind. All these problems led to the census and the MDA taking a lot longer than was planned, so months longer than was being planned, and you imagine you've got thousands of drug distributors out there for months rather than weeks. There's all sorts of issues apart from just simply the cost. One of the things they needed to do was try and conduct the census independently from the distribution, and that wasn't happening. So the idea of the census, it tells you what you need to do with the Mass Drug Administration, how many drugs you need, for example. If you're not able to do that independently, you're just basically just ramming drugs out into the field and hoping you've got enough, and not worrying about what happens if you have a surplus. So it enabled them to introduce some control. So they could say, okay, well, look, we know this is what we need, so this is what we'll send to the field. So it's much more cost-effective and much more effective use of commodities. And simply the areas, some of the accessibility of some of the areas is very tough, so being able to get data out of them is a hard call. So they were the issues, the problems really, and why they came to us. So what do we do? So we always try and break things down to the simplest possible way of working. So what we did with Site Savers is, okay, well, what are the key bits of information you need from the field and they identified these indicators for their MDAs. So we worked with them and said, okay, well, look, if we're going to be using SMSs have to be short for a number of reasons. One is there's a technical limitation on the length of an SMS, and secondly, you imagine big fingers, tiny keyboard, you know, it's got to be simple to use. So we just basically said, okay, well, look, give an alphabetical code to each of those indicators, and then put a number, the aggregated number for that day or that week after each letter, and send it in. And what we also did was built a gateway that connects to all of the mobile network providers in Cameroon, and configured that with a short code number, which is 8005, and also negotiated with the mobile network operators to make that free to use. So the health workers don't even have to have credit on their phone. They can still send and receive messages for that number. And the SMS costs are paid for by the programme. So for them, for the health workers, or the community drug distributors, it's easy, it's free to use, doesn't cost them anything, and it's quick. So that's what they did. They basically, Mango was configured so that every reporting period, whether, I can't off the top of my head remember if it was weekly or daily, I think it was weekly, Mango would automatically send out an SMS request message to all of the registered drug distributors with a simple message saying, please send in your count for this reporting period. They would then go to the notebooks, add up the numbers, and then assign the code in this SMS format and send the message back in. So that's getting data in from the field. So what happens to the data? Well, as soon as the data comes through the gateway from the network, which is, you know, instant, instead of hitting somebody's phone, it hits our database, and then Mango takes over and generates reports, charts, maps, runs algorithms on the data, throws up whatever calculations they've asked for to therapeutic coverage area, and if the data collectors have broken their data down by age limits, for instance, under 5, over 5, you know, we can start to produce information from the data that's meaningful to the program managers. So things like the system will automatically generate reports, charts. We can overlay this data onto maps. We can relate it to the disease prevalence, you know, are the commodities where the disease prevalence is, for instance. And so it's real time, updated every 15 minutes. So anybody, anywhere, can see exactly what's going on right up to the last 15 minutes, basically. That data's in a SQL database. So if you need to extract it to do further analysis in other systems, you can extract it directly from the individual charts. You see there's an Excel button there. You can pull it out in multiple formats. You can print it. You can basically do what you like with it. You can filter as well. So if you need to filter down to certain parts of the country, there's various filters that we can deploy. So going back to Cameroon, so what happened? Site Savers came to us with a problem. They made an investment. They ran the MDA, and headline results came through at the end of the year, 2014. And as you can see, the results are very good. Otherwise, I wouldn't be here talking about it. But so the results are very good. So significant increase in the number of persons censored compared to the previous year. Significant increase in the number of persons treated. Reduction in the refusal rate. Not quite sure how that's related to what we did, but it's good to see. Early notification of adverse reactions, very key. You know, that people get an adverse reaction, someone needs to do something about it very quickly. So they could notify that straight away, because that was one of the other indicators that we had outside of the regular routine data collection. Big reduction in the amount of time taken for the MDA. They reduced it by a third. So instead of 3 months, it was 2 months. Effective management of activity in the districts and health areas, so the program managers can see what's going on all the time, and if they spot any anomalies or anything they think is going wrong, they can contact the lead guys in the field straight away. And real-time reporting. So what they found was that during the appraisal period at the district level, they had 90% of the community-based data available, and by the time we got to the regional evaluation, they had 100%. To put that in some kind of context, the way they did this in Cameroon last year was they, in the southwest region, they split it in two.
So they ran a control error, if you like, using the traditional approach and the mHealth intervention in the other. And you can see if you look at the timeliness and reporting, using the traditional approach, they only had 40% of the data at the district evaluation, and I can't see what it says, 55% at the regional level compared to 90 and 100%. And it also took 3 months instead of 2 months, so it's a massive difference. So yeah, based on the results that they've seen, they're expanding the systems, expanding the use of the system sixfold this year. So instead of running it in half a region, they're running it across 3 whole regions, and they're in the planning stage for that now. I think that's due to start next month. So that's a real live application. We've got lots of others. The diagnostic test data application that we're working on with Omega. Patient adherence, we do a lot of work with patient adherence to send people reminders when they should be taking their drugs and to alert community health workers or family members if they don't come to clinical assessments. We do a lot of client management of client files, e-vouchers and referral systems. Supply chain management is where we started, and a lot of early warning systems, so epidemics, adverse reactions, that kind of thing. The key benefits that when you spend money on this type of application, you really want to understand why you're spending the money. You want to get some benefits and value for your spend, and we've seen the benefits that Site Savers identified, and they're common. So massive time savings, big savings in money, because time is money effectively, and if you can use commodities, for example, effectively, you're saving money as well. Real-time informed decision-making, big reductions in stock-outs. We've got some great evidence-based case studies based on stock-out reductions, Kenya as an example. Forecasting, you can, once you build up a data set, obviously you can start to forecast backwards and forwards. We can manage order placements, order processing, reduce waste in overstock. So even in the NTD program, they were able to just push out the drugs that they needed, not oversupply the drugs or even undersupply. We can enable real-time data exchange with other systems, so LMIS systems, health systems of multiple types. We also use Mango to support lots of training activities. So training is one of the biggest overheads that ministries of health have. So if you can push your training materials down electronically, rather than pulling people in at $70 a head per day, it's a massive cost saver. And people like it because it makes them feel involved. High accuracy and reporting rates, so because people tend to embrace and engage with this type of data collection, reporting type system. So we see very high, even in Cameroon, I think it's up around 80%. Every week, 80% of the people send the data in. So you compare that to the traditional ways of reporting. Not only does the data come in much later using the paper-based reporting, but you only typically get half the people in the country reporting. So much higher reporting rates and much more accurate because you can automate the system to say, okay, well, if anything looks unusual, send an alert to somebody or send a query back. Are you sure these are the right figures? High staff motivation. We did a part of the evaluation in Kenya was to go around and find out what people thought about the system, and a lot of the feedback we've got is great because it makes us feel, you imagine yourself in a remote facility, and you might get a visit from a district manager once a month or once a quarter. If you're getting weekly communication with the program that you're working for, it makes you feel like you're actually contributing and part of the health community, and real-time data validation. I think I've done 10 minutes. That's what Cameron told me I had. But, Good. Cameron.
Thank you very much, Andy.